Hello again, everybody. Here we are once more in our medication and mental health series. I know that I've missed part number 3, I think. I'll come back to that a wee bit later because it's quite really about some rarely used antidepressants. So I want to kind of catch up as we go along with other medications. So in this probably slightly longer presentation, I'll discuss in the main antipsychotic medication, atypical and typical antipsychotics. Here I want to kind of cover the accepted structural changes, so that's changes that are observed in areas of the brain and functional issues as well, so the neurochemistry related to psychosis. I think we should look at the action of atypical antipsychotics and typical antipsychotics. Spend a good bit of time thinking about side effects, some discussion about depot medication, and just some special considerations relating to some particular antipsychotics. So we can start really by looking at the structural and functional issues. I think while we can accept that psychosis is probably a combination of a variety of stress and vulnerability issues, there are some structural observations of people with schizophrenia that have been observed. So it's been observed in the limbic system, for instance, of the brain. There is a lower volume of cells in the hippocampus, parahippocampus, and thalamus. And these are the areas of the brain that are concerned with the emotional life of the person. So they're strongly linked to emotion, behaviour, motivation, and long-term memory. It's also been observed that there's a decrease in neural density in the superficial white matter of the brain and an increase in the deep white matter. Some observations report an overall reduction in neuron density in white and grey matter and some ventricular enlargement in some areas of the brain. So quite major structural changes in the brain. I think caution should be advised in reliability of some of these observations. There's some criticism that these observations have not been robustly tested against the normal brain, inverted commas, and that in many cases brains are being examined after long-term use of medication. So who knows? But these are the accepted norms. Functionally, we're back to the notion and the action of neurotransmitters. In the case of schizophrenia, we're thinking about the dopamine theory. So simply put, the idea is that there's an overactivity of dopamine in some of the critical dopamine pathways of the brain, and that leads to positive psychotic symptoms. Alongside this, there's an associated lack of dopamine in one critical pathway that's thought to lead to negative symptoms. So the neurotransmitter implicated in psychosis and schizophrenia is dopamine. So let's talk about some typical antipsychotics which are listed on the left there. So the action of typical antipsychotics is and was to block dopamine receptors in the synaptic gap, which you can see there in that little diagram. The problem with these antipsychotics is that while they were fairly effective for treating positive symptoms of psychosis, they do tend to worsen negative symptoms and have worse extrapyramidal side effects, which we'll look at later. So on the whole, atypical antipsychotics would be preferred. However, many patients still have a better response to typical antipsychotics, prefer these medications, or cannot tolerate other medications. So you may still see these used commonly in practice. So you should be aware that negative symptoms are less likely to respond to typical antipsychotics. Atypical antipsychotics means one of two things, basically. It means that they can treat psychosis without causing extrapyramidal side effects, or there's something called a high dissociation constant. Now that's really a chemical term relating to the pharmacology of the medication, and it's about biochemical equality and equilibrium in the brain. So in relation to that first point here, atypical antipsychotics also act on serotonin receptors as well as dopamine, and that means that they can have a better action in negative symptoms as well as treating positive symptoms. By this action, some dopamine pathways, there's also reduction in extrapyramidal side effects due to this chemical action. So because the dopamine's been impacted in some particular pathways, side effects are reduced somewhat. In relation to the dissociation, this relates to chemical equilibrium, and basically in the brain, atypicals can keep prolactin, a hormone, at a normal level as opposed to with typical antipsychotics, which would decrease or increase prolactin. So atypical antipsychotics maintaining an equilibrium and again reducing side effects. And side effects excuse me, are a major issue when we're thinking about treating people with antipsychotics. I'm going to go through side effects in a number of areas. So let's start with something you might have heard of called extrapyramidal side effects. Starting off with dystonia, which is an abnormality of muscle tone, muscle spasms, your jaw forced open, and also laryngeal spasms. Acute dystonia can be very common with first generation antipsychotics, and that should be treated with an anticholinergic medication like prostaglandin, which I'm sure you've seen used in practice. Akathisia is another APS, and it's a subjective feeling of muscular discomfort and restlessness, and a compulsion to move legs or stand up. And you might often have seen people in sitting rooms shaking their legs or suddenly standing. That could be in relation to akathisia. Pseudo-Parkinsonism, so things like stiffness, rigidity, shuffling gait, drooling, stooped posture, as a action of the extrapyramidal side effects. Tardive dyskinesia is symptoms like endless involuntary movement of the jaw, tongue, the trunk and patient's extremities, and maybe very irregular movement, like if you've seen the movements of somebody with Huntington's chorea, they might move in their limbs in that way. The most common ones are things like lip smacking, protruding movements with the tongue, chewing, and lateral jaw movements, also facial grimacing. These usually occur 6 months after starting typical antipsychotics in particular. And one of the issues here is that these can be irreversible in some cases, and it adds to the patient's feeling of disability and oddness, because they look slightly odd in that situation. There's also a number of APSs which are hormonal. So for females, that can include irregular periods, discharge of breast milk, excessive development of the breasts, acne, excessive facial and body hair. For males, that could include also enlarged breasts and decreases of body and facial hair, but also impotence and ejaculation problems. And I think probably sexual side effects are underreported in this group, often because people don't ask about them. For both groups, actually, because of issues with prolactin, especially with typical antipsychotics, issues of low bone density, loss of interest in sex, headaches, visual disturbance and infertility are problematic. So we can see why perhaps the typical antipsychotics should have gone out of favour, because they obviously have more extrapyramidal side effects, and these side effects can be particularly distressing for patients in the short term and the long term, and can actually cause a problem with compliance concordance. There's also a number of non-extrapyramidal side effects, things you would expect, like dry mouth, blurry vision and constipation, also dizziness, low or high blood pressure depending on the mechanism the antipsychotic used, and drowsiness. Metabolic syndrome is an issue for patients in terms of their own life expectancy and their basic physical health. Metabolic system would include things like weight gain, high blood sugar, excessive body fat, and abnormal cholesterol. So partly as a mechanism of the medication, as well as poor diet, feeling and neglecting self. So as nurses, it's important that we keep a lookout for that. Hematological effects, that could be a reduction in white blood cells in bone marrow and can lead to agranulocytosis, which you might be aware of from clozapine, which I'm going to come on to a little bit later on. Also cardiovascular side effects, and most importantly, sudden unexpected death can occur in patients. Low blood pressure, congestive heart failure, myocarditis, in other words, inflammation of the myocardium in the heart, and finally, for non-extrapyramidal side effects, an increased seizure risk. Now, like any drugs, not everybody is going to suffer from every side effect, but for us as nurses in practice, we need to be aware when there's a change to a patient's physical state or emotional state, psychological state, cognitive state, that it could be a consequence of a side effect of medication. We need to talk about neuroleptic malignant syndrome, which is similar in some ways to serotonin syndrome, which we talked about in the other presentations. So this is a potentially fatal syndrome. It's got an incidence of about 0.02% of people who are prescribed antipsychotic medication. Obviously, a quick medical response is required. It's not common, but it's important for us to know about it. There's some external symptoms such as hypothermia, muscle rigidity, that was hyperthermia, not hypothermia, muscle rigidity, mental state changes, slow movements, and also profuse perspiration. Some of the internal signs would be things like blood pressure instability, tachycardia. We'd also might observe altered consciousness, and there might also be high serum levels of the enzyme creatine phosphokinase and an increased white blood count. So obviously the medics would send, or you might, once you're trained, send off some blood to check what's going on with somebody. So it needs intervention, but also recognition. This can happen at any time, but may be more common in people who have been taking antipsychotic medications for some time, and more common generally in typical antipsychotics than atypical. Just want to have a wee look at this table here, which is quite an interesting illustration of how different types of typical and atypical antipsychotics have different effects and side effect profiles. So for instance, if you look on the left hand side at haloperidol, it might be the best choice for avoiding weight gain, but it's the worst choice for extrapyramidal side effects, and it kind of lies in the middle for its sedatory effects. Clozapine is the opposite. It's one of the worst choices for weight gain, but one of the best choices for extrapyramidal side effects. It's also the worst choice for sedation. So you can see there's always a balancing act to be done in relation to treatments with medication, and us as nurses being able to advise our patients about what the best choices might be for them. Obviously we work as part of the multidisciplinary team, and we're looking at quality of life as well as symptom reduction and the patient's ability to function in an appropriate and fulfilling way in their recovery. So I think that's an interesting table just to browse. Many of our patients will receive their medication by depot rather than oral medication. There's advantages and disadvantages to that. I mean, depot medication is commonly used, and it's almost always in the gluteal or deltoid muscle. And really it does improve concordance and also ensure that there's a link kept between the patient and their clinician. So obviously there's a reduced risk of a missed dose or an accidental overdose, and there's maybe potentially better patient outcomes and patient satisfaction with depot. In saying that, there are disadvantages, including the stigma of coming to a depot clinic, inverted commas, on a monthly or fortnightly basis, travel to the clinic, pain at the injection site, student nurses practicing on poor patients at the depot clinic, and there's also a lack of flexibility for titration and dose adjustment by depot medication. I think depots probably indicated where people have a lack of insight. Maybe they also use substances that they shouldn't, or they might have a lack of routine or significant community support. So it is an option, and it should be used for people who are most likely to benefit from the depot. Just a brief discussion of three special considerations. Clozapine, as I mentioned, was actually originally introduced in the 1970s, but was actually withdrawn due to deaths from agranulocytosis. But came back into vogue in 1989 and back in use as an atypical, but obviously with a strict gradual introduction regime, monitoring, and as you'll know, mandatory blood monitoring at clozapine clinics usually. As nurses involved in that, we need to be concerned if a patient's temperature is rising above 38C, they've got a pulse over 100 beats per minute, they've got a postural blood pressure drop, or they're reporting any other intolerable side effects, obviously with the risk of death from agranulocytosis. We need to be very aware of the physical implications here. Oh, sorry, didn't mean to do that. Acinapine is another atypical medication, and that should be administered sublingually, as it cannot be absorbed into the bloodstream via the stomach. So one of the issues here is that patients should be advised not to eat or drink for 10 minutes after administration, or it will impact on the amount of the medication that's been taken into the bloodstream. So there's no point administering sublingually and then having a cup of coffee and washing it all away. And finally, olanzapine palmitate is an atypical available via depot, and one risk here is in relation to post-injection delirium or sedation syndrome. The most effective way to prevent that with this drug is proper injection technique with the correct size needles, proper aspiration to make sure you're not going into a blood vessel. After injection, patients should be observed for 3 hours, and their vital signs should be monitored. We're particularly concerned for signs of delirium like disorientation, confusion, ataxia, irritability, anxiety and aggression, and obviously sedation, sleepiness or changes to consciousness level. So folks, that's a longer presentation than normal. I think mostly because the side effects of antipsychotics are important for us to really consider our role in that. Hopefully you can understand the action around about dopamine for typical antipsychotics and dopamine and serotonin for atypical antipsychotics, and the difference between them. So thanks for listening. Sorry it's a bit longer than usual, and hopefully it's useful to you. Bye for now. See you in the next one.